Hello, everyone. I have the pleasure of introducing Dr. Batra. He is a UC Irvine Health pediatric cardiologist who specializes in electrophysiology, arrhythmia management, and device implantation. He is vice chair of UC Irvine's School of Medicine Department of Pediatrics and chief of its division pediatric cardiology. He is also the medical director of the electrophysiology at CHOC Heart Institute in Orange. He earned his medical degree at Ohio State University in Columbus, Ohio, and completed his internship, residency, and fellowship at Children's Hospital of Los Angeles. He is a certified American Board of Pediatrics in general pediatrics and pediatric cardiology. He is also certified in the Heart Rhythm Society for pacemaker and implanted ICD management. Dr. Batra research and scientific findings are reflected in more than 60 publications in prestigious national journals and textbooks. He is an internationally recognized lecturer who is known for his work on the prevention of sudden cardiac arrest in children and adolescents. He sees patients at the UC Irvine Health Pediatric Cardiopulmonary Clinic, as well as Miller's Children's Hospital in Long Beach and CHOC Hospital in Orange. Please welcome Dr. Batra.
Thank you, Samantha. Am I good to go, Tomas?
Yes, thank you.
Okay, wonderful. Good evening, everybody. And, first of all, I want to start off by saying what a privilege it is at this late an hour in the evening for all of you to take time. I know you've been working hard. It's been a busy day. You all want to go back to your families and probably not had dinner yet. So I promise you, I won't keep you any longer than the time I've been allocated. I'll try to leave some time at the very end for some questions. The talk we're going to do today is on sudden cardiac death in athletes. It's a topic that, it touches us. I don't care what field we are in, whether we do, oncology, endocrinology, ID. It's a field that, comes close to us. And not only in our medical practices, but, we all have family members, we all have kids. And the question is always on the back of our mind, what should we be doing? How should we be preventing the sudden cardiac death in athletes? The cases we hear about, they are not as common, but when it happens, boy, it does hit home and everybody's asking questions. So I'm going to try to break it up into 3 different sections today. We'll talk a little bit about the epidemiology. How often does it really happen? How do we determine, what the incidence of sudden cardiac arrest / sudden cardiac death is? Then we'll talk a little bit about what causes it. So I think to really, if you want to get into the screening techniques, what we are going to use, the tools, we need to have a little better understanding of what we're really looking for and what it means and how do we pick up these different diagnoses, at least the common ones. So I'll touch briefly on each of the different reasons or the causes of sudden cardiac arrest that happen on the field. And finally, I'll finish off with the current screening tools that are out there, the AHA 14-question screening tool and the AAP tool, the 4-question tool that's out there. How good is it? Well, how do we use it? And that's where I'll finish with. I'm going to, like I said, leave some time for questions, but just to make it interactive, one of the requests I'm going to ask for those of you who can, and just for the fun of it, I put some questions during my talk, an audience response. There's only about 4 of them. So if they come up, please try to answer the audience response questions. I promise you, no one's going to know who answered what. It's just for fun. And I will touch on it and I will go over details of the answers. So I think it's more interactive and more fun. Also, there's a lot of very intelligent people on this talk right now. Many of you, I can see familiar faces. If there are things that come up, things that you want to, share, please feel free to use the chat box. And I'll try to use it as much as I can. So with that, I'll get started. I may ask those who are not on to just mute yourselves. Thank you very much. And here we go. So objectives we talked about already, so I'm not going to get into that in too much, go over it again. And when we talk about the incidence, right? We're talking about the incidence of what? Most commonly, we talk about incidence of sudden cardiac death in athletes. Now, Are we talking about sudden cardiac death in athletes, or are we talking about sudden cardiac death in the young? And if we talk about sudden cardiac death in the young, do we include the patients who are less than 1 year of age? Right? They're not athletes, but there is definitely a high prevalence or incidence of sudden cardiac death in the first year of life. So what I'm getting at is we have to define that better. Not only do we have to say, and then if you're talking about sudden cardiac death, we also have to differentiate that from sudden cardiac arrest. Oftentimes we hear about somebody who collapsed on the field, on the basketball court, on the soccer field, but got appropriately resuscitated. So that's very different from sudden cardiac death because it's not going to fall in that category. It's going to be more in the category of sudden cardiac arrest. And how do we collect that data? So most of the studies that have been done, the epidemiological studies, really, they look at media reports, registries, autopsy reports. And we all know that there are cases that will be missed. For instance, in Orange County, Children's Hospital of Orange County is the main hospital, but there are at least 10, if not greater, outlying hospitals where if there is a sudden cardiac death, the emergency paramedics will take them to the nearest hospital. And if the patient does not survive, that will not get counted anywhere. There is no central registry in Orange County or in any county that I'm aware of. So oftentimes these cases will be missed and the numerator will be much smaller than what it is. And the denominator is also important. Who are we looking at? I told you. Is it just athletes? How do you define an athlete? Is it all young kids? At what age do we start? And at what age do we cut off? At what age do we say they're no longer young? So defining that makes a big difference in the numerator and the denominator and the incidence of sudden cardiac death / sudden cardiac arrest. According to the CDC, about 2,000 young healthy people under the age of 25 each year have a sudden cardiac arrest. This number may seem high to some and may seem low to others. But one thing is for sure, that each individual cardiac arrest or cardiac death that happens in our community shakes us all up. And we are all wondering, could this happen to our patients or could this happen to our children? And it has a profound effect not only on the individual's family, but on the local community. So the gravity of each incident is much greater than, if it was not a young patient. So we'll do an audience response. For those of you who can, please try to respond. The question is, incidence of sudden cardiac death is greatest in which of the following age groups? 1 to 4, 5 to 9 years, 10 to 14 years, 15 to 19 years, or 20 to 24 years. We'll give about 30 seconds. So which age group has the greatest incidence of sudden cardiac death? All right, excellent. Thank you, folks, for participating. I love it when I get a lot of responses. And you can see the responses are, pretty much all over, but a big chunk is 15 to 19 years of age, because in pediatrics, that's our oldest age that we pretty much deal with. After they hit 20, they pretty much, a lot of them end up going to adult internal medicine. So let's look at that. We go to the next slide. We can end the poll and go to the next slide. Did we share the results, by the way? I think everybody got the results, right?
Results were just shared. Everybody should be.
Everybody got to see what the results were, what everybody polled. 15 to 19 years was the majority of the people picked, and then anywhere between 10 to 14 or 20 to 24 was the next subset. And if you look at the data, it's not letting me go to the next slide. Okay, there we go. Thank you. And you can get rid of the polling slide. I think if it's showing up for you guys, you can just delete it. So there's a high incidence of sudden cardiac death in the first year of life. Then it drops after the first year of life. Fairly low between 1 to 14 years of age. And then as soon as they start going to their high school years, they become more athletic. The incidence starts to go up, 15 to 19, and continues to go up 20 to 24, 25 to 29, and 30 to 34. But what you'll also notice is after age 25, ischemic heart disease, which is the blue part of that graph, starts going up exponentially and gets significantly higher. So if you take ischemic heart disease out of the equation, it still goes up and it continues to go up after age 15. So 20 to 24 would have been the correct choice in this age for this question. But again, I understand, a lot of pediatricians don't see this age group. So 15 to 19, if you pick, that's absolutely understandable and the correct answer. So now let's look at why, what I'll do is I'll break up the less than 1 year of age and then after 1 year of age, because the reasons for the sudden cardiac arrest / death in the first year of life are generally very different from those later in life. If you look at infancy, unrecognized congenital cardiovascular malformations, particularly the ductal dependent abnormalities or obstructive left heart malformations, are a big chunk of them. What is included in this? Hypoplastic left heart syndrome, coarctation of the aorta. And one may ask, well, nowadays we do screening. Don't we pick these up on the screening exams? Not always, especially the left heart lesions, because they are not necessarily cyanotic lesions. Their saturations may be okay because they have a duct open in the first 2 days of life. And as soon as the duct starts to close, then it becomes a pressure limited or a volume limited lesion where the coarctation isn't letting blood get through to the systemic circulation, or in a hypoplast, too much pulmonary blood flow, but very little systemic flow. So those kind of lesions can still be missed. And these patients either show up really sick to the emergency room or can have sudden cardiac death at home. Another common cause in infancy is fetal arrhythmias. Unrecognized atrial arrhythmias, ectopic atrial tachycardia, supraventricular tachycardia, or ventricular arrhythmias are also causes in the first year of life. Heart block, unless we do an EKG, which we generally do not do that in infancy, can be missed, and they can have heart block, a complete AV block, and that can be a reason. And a substantial number of patients have now undergone congenital heart surgery. They got picked up, they had, palliative surgery, but it's just palliative and they remain at risk of sudden cardiac death. So that's another class of patients who can present with sudden cardiac death in infancy. Once we get beyond the first year of life, here's a question. So beyond first year of life, and the question is, which of the following statements is not true? So all of them are true except one. A, men have a much higher rate of sudden cardiac death than women. B, majority of deaths in athletes occur during exercise. C, sudden arrhythmic death syndrome can be a common cause of sudden cardiac death. D, hypertrophic cardiomyopathy is a relatively rare cause of sudden cardiac death in the US registry. And E, the risk of sudden cardiac death in Black athletes is greater than that in white athletes. So one of them is not correct. All the other four are. And thank you again for all those who have been responding. I love it. Questions coming through. We'll give about 5 more seconds. And okay, we can share the poll at this time. And the correct answer, which it's the wrong choice, is number D. So hypertrophic cardiomyopathy is not a rare cause of sudden cardiac death in the US registry. It is actually the most common cause of sudden cardiac death in the US registry. The rest of them are correct. Men have a much higher risk of sudden cardiac death than women. majority of athletes, it occurs during exercise. Sudden arrhythmia death syndrome can be a common cause, and Black athletes are at greater risk than white athletes. Okay. Go on to the next slide. Okay. So talk about some of these individually. Exercise-associated sudden cardiac arrest, or what is the definition of exercise-associated sudden cardiac arrest? It's an event that occurs either during exercise or within an hour of exercise, before or after. There's certain events or certain sports that have a much higher risk associated with sudden cardiac death. And those are men's basketball, men's soccer, and men's football. And studies suggest that some studies say up to 90% of deaths in athletes occur during exercise. Others suggest 50% or greater occur during exercise. But either way, whatever that number is, it's definitely greater during exercise than not during exercise. So the reason to know these facts or these important, what these studies are bringing out is, when are you going to be most vigilant? If you had an AED, where would you put it? Clearly men's sports. What sports? During activity. So that's where, if you had a choice and you had to pick resources, you would direct them towards where you would get the greatest chance of it being used. We talked about this. Men have a 3 times greater risk of sudden cardiac death when compared to women. And if you look at the US registry done by Dr. Barry Maron, now granted, this is a little bit of an older study. It was published in 2007. Hypertrophic cardiomyopathy was the most common, which is the blue part of it, the light blue on the bottom, most common cause of sudden cardiac death in US athletes. Okay, we'll talk a little bit about hypertrophic cardiomyopathy. But since that study, there have been other studies that have come out. One came from the United Kingdom. One looked at particularly US military people. Another looked at NCAA athletes. And they still found hypertrophic cardiomyopathy to be significant, but not as significant as the Barry Maron or the first study that was done. What they found was a much higher incidence of sudden unexpected death, or sudden unexplained death, which is most likely an arrhythmogenic death. Okay, so it depends on how you look at it. If you're looking at autopsies, you are not going to identify the arrhythmia. So if you have a sudden unexplained death, you don't know what happened. A young athlete came to the ER. You do the regular autopsy, you're not going to find anything. But if you were to do a molecular autopsy, which is genetic testing, what percentage of these patients that had sudden unexplained death have a genetic etiology? And there was a study that looked at that. And what they found was over 50% of the sudden unexplained death patients had an identifiable genetic etiology. That included long QT syndrome, Brugada syndrome, arrhythmogenic cardiomyopathy, different other cardiomyopathies. And this is also now a relatively older study. There is one diagnosis over here that is missing that we have gotten better at identifying and recognizing. That diagnosis, which is not on this slide, is CPVT. I don't know how many folks over here are familiar with this diagnosis, but if you're not, and this is the one message, take-home message you can take away from this talk, I think I will feel that this talk was successful. So CPVT stands for catecholinergic polymorphic ventricular tachycardia. It's a genetic condition. And what happens is, if you did a baseline EKG and even an echocardiogram and an exam, you're going to be normal. But once these kids' catecholamines go up, which means you exercise them, they go into an arrhythmia or a ventricular tachycardia and have sudden cardiac arrest, sudden cardiac death. How common is it? Well, when I started at CHOC in 2006, no, people were just getting to know about this diagnosis. And really, in my first year in this hospital, we had 5 patients present with sudden cardiac death in 2006. We felt that was a pretty high number, and we needed to start looking at what the etiologies were. So we started collecting data just at our own institution. And what we found was long QT syndrome, which is on the slide, remained the #1 reason for sudden cardiac death, but CPVT was the #2 reason for sudden cardiac death. So there is a substantial part of this pie which can be explained with CPVT. And how do you identify CPVT? How do you pick up CPVT? Well, if somebody comes to you with exercise-induced symptoms, especially exercise-induced syncope, that should be a red flag. Send them to a cardiologist, and the cardiologist should do an exercise test on them. Make them run on a treadmill. Family history would be very helpful because this is an autosomal dominant condition, which means somebody in the family, first degree relative most likely, would have had either a sudden cardiac death or had syncopal episodes. But the key word here is exercise. Very different from vasovagal syncope, which all of us see. We see a lot of it, and it's a benign condition, which is basically treatment is, hydration and sitting down, and they don't necessarily need a referral to a pediatric cardiologist. Okay, so 90+% of the syncopal episodes are going to be vasovagal, but the rare exercise-induced syncope, CPVT, please, that's the one message I want everybody to kind of put in your minds. So now I'll go through some of the other conditions relatively quickly. Hypertrophic cardiomyopathy, we talked about it being a very common condition, but #1 condition for sudden cardiac arrest and sudden cardiac death in the US at least. Prevalence reported as high as 1 in 500, and as many as 36% of the sudden cardiac death cases explained with hypertrophic cardiomyopathy. What happens is the heart muscle becomes thick. Again, it is an autosomal dominant condition, tends to run in families. So family history is very important when you ask them. And not all hypertrophic cardiomyopathies are the same. You want to, once they have hypertrophic cardiomyopathy, you have to see how thick is the septum. Are they having any ventricular arrhythmias? Have they had any syncope? So those are the kind of things that will determine how restrictive we are going to be in terms of letting them play sports, whether they need an ICD or not, etc., etc. But yes, if you're worried about hypertrophic cardiomyopathy, don't send them to a pediatric cardiologist. Also, I am going to say EKGs are very, very poor for picking up hypertrophic cardiomyopathy if you just look at the forces, if you just look at how tall the R waves are. But there are other things on an EKG, such as T wave or ST segments, that are actually very highly sensitive and specific for picking up hypertrophic cardiomyopathy, especially if they're having a strain pattern. So EKGs can be helpful for hypertrophic cardiomyopathy, but also have a high false positive rate. Arrhythmogenic cardiomyopathy, which we don't see a lot of it in the US, and I don't know why. Is it because we are not good at diagnosing it, or we just don't have, or our patient population is different? But if you look at least a large study that came out of Veneto region of Italy, arrhythmogenic cardiomyopathy is the most common cause of sudden arrhythmia or sudden arrest in those that are less than 35 years of age. And what happens is there are fibrofatty infiltrates that come into the myocardium and have a tendency to cause arrhythmias. Again, autosomal dominant, genetic testing can be helpful in terms of recognizing and determining it. Also, an MRI is a helpful tool if somebody's having a lot of ventricular arrhythmias. Abnormal coronary arteries, fairly common. Mostly, you can either have the left coronary artery coming off the right or the right off the left, The left off the right is the one that we worry about more, and also the angle of the takeoff. This is a tough one to pick up because if you do an exam, you're not going to pick it up. If you do an EKG, you're not going to pick it up. And even an echocardiogram, unless you look for the coronaries and somebody who's really, does this all the time, like an echocardiographer, there's a high likelihood if somebody's just doing screening echoes, they can miss this diagnosis. And I think everybody heard of Bronny James, right? It's all up in the news, all over the place. And so I'm going to share his story. He had a sudden cardiac arrest while playing basketball. And he was not the only one. There were 2 athletes within the last year at USC basketball team that had a sudden cardiac arrest. Now, the good news, Bronny James did great. He was resuscitated appropriately, got great medical care. And this news article came out about 2-3 weeks ago, where he was diagnosed with a congenital heart disease that caused his cardiac arrest. And the latest news that came out this week that the congenital heart defect was corrected, and he is going to return to play basketball this year. At least that's what LeBron James said. So what is the congenital heart defect that caused Bronny James' cardiac arrest? We can all, and I don't know this for a fact, but we can all assume that Bronny James had some sort of screening. He's an NCAA athlete. He had some form of screening. And the most likely cause, and again, I don't know this for a fact, would have been an anomalous coronary artery, which is a correctable cardiac lesion. So I'm just using him as an example. If you surgically, you can correct the coronary artery and put it back, and patients go back and they can return to sports. Now, what's important over here, the message over here, is that resuscitation, appropriate resuscitation, and having a defibrillator is very important in these scenarios as well. Aortic dissection associated with Marfan syndrome. Again, I don't see this very often. I do see Marfan's patients, and they can have aortic root dilation. I think this happens at later age, and hence we don't see it as much in pediatrics because the aorta gets gradually dilated as they get older and over time. So we don't, I personally have not seen the complications of Marfan's with aortic dissection, but I definitely do see patients with Marfan's, and I do see patients with dilated aorta. Myocarditis, this is another difficult one. We all have viral infections, and sometimes the viral infection can affect the myocardium, the heart, and cause myocarditis. What happens is the myocardium gets inflamed. You have a tendency to have arrhythmias. There unfortunately is not much in terms of treatment, especially for viral infections. You just let it take its course. You let them rest. And once the virus gets better, most often the myocarditis gets better and they can return to sports. But while they have the myocarditis, while they have the infection, they are at risk for having arrhythmias. And if they are participating in vigorous activities, they can have a cardiac arrest. Difficult diagnosis to pick up. And COVID, we can't ignore that, right? Everybody's asking the questions about cardiac involvement with COVID vaccine. Everybody's asking involvement with, COVID and the cardiac involvement. And have we seen cases? Yes, we have. We've seen cases, but the only thing I can say is that the cases post-COVID that I've seen of myocarditis are much more significant than anything I've seen related to the vaccine. So I advise every patient that comes to me to say that you have to do everything, including a vaccine, to prevent from getting the COVID. And yes, it can impact the myocardium. Stimulant medications, this comes up a lot. We get referrals multiple times, multiple referrals of patients who are going to be on stimulant medications. And at least if you look at the epidemiological studies, there is no effect on sudden cardiac death prevalence from the stimulant medications. And these medications will have small sympathomimetic effects, which means they'll increase the heart rate just by a little bit. But in somebody who otherwise has a healthy heart, stimulant medications don't increase the risk of sudden cardiac arrest and sudden cardiac death, at least based on the studies. Commotio cordis. This is a diagnosis that is a very rare diagnosis. It's seen mostly in athletes between the ages of 8 and 18 years of age. If you look at the data, they say 20 to 30 deaths per year, and 95% of the cases occur in males. What happens in commotio cordis? It is a sudden hit to the chest. Either a hockey puck, golf ball, any or karate, different sports, even football, where you can get hit in the chest. But it's a matter of timing. It's not just getting hit in the chest. It is getting hit in the chest at that exact timing when the T wave is starting to go up, when the repolarization is starting. And that can trigger a ventricular arrhythmia known as ventricular fibrillation. So if you look on the bottom part of the schematic, the diagram that I have, you see how the red line is right where the T wave is starting. And you have to get hit exactly at that time to induce this ventricular fibrillation. These patients are otherwise healthy, and the only treatment is appropriate resuscitation and a defibrillator. Do we see examples of this? Here, and here's one that I'm going to share with you. I think many of you were there. I was there watching Damar Hamlin Monday Night Football last year. And let me see if I can play this. And there's Damar Hamlin, number 3. He gets hit in the chest.
Not what any of us want to see, and everybody's around him, and let's hope that he's going to be okay. So we'll take another break here in Cincinnati.
So Damar Hamlin was otherwise completely healthy. He had no cardiac condition. This is an example of commotio cordis, where he gets hit in the chest right at that timing. And again, the take-home message from this was there were great trainers. There were people who were trained in CPR. They had an AED. He got appropriately resuscitated. He was in the hospital for a total of maybe 2 days, got sent home, and he's back to playing football this year. So, getting back to the incidence, the prevalence of sudden cardiac arrest, sudden cardiac death, there are, people have realized we need to know what the incidence is. We need to know how often does it happen. And so at least as a first stage, both the NIH and CDC have put some funds. They are trying to gather information so we can learn more about children up to the age of 20 who die suddenly. But they can't do it in every county in the entire country. So they've picked certain counties and certain states, as you can see in that picture, that are participating. The goal is to collect the data. And remember, this is sudden cardiac death, not sudden cardiac arrest. And if you ask me, I think the incidence of sudden cardiac arrest is at least 3 times, if not greater, than that of sudden cardiac death, right? Because defibrillators and AEDs have become very available now, and many patients who have sudden cardiac arrest get appropriately resuscitated. I think we've come a long ways from when we started. In 2006, when we started, at least in Orange County, none of the schools had an AED. And now if you look at them, thanks to support from all kinds of resources, the AAP, the different parents organizations, the nurses, the schools, majority of the schools, at least the high schools now, have an AED available on site. So, and I've seen so many examples of patients that have been appropriately resuscitated and are doing well because they had a sudden cardiac arrest and not a sudden cardiac death. So now what I'm going to get into is the final part of my talk. I told you about the screening questionnaires that the general pediatricians deal with. I think these come to you all the time. This is the one from the American Heart Association, which is probably the most commonly used screening tool. It's a 14-point questionnaire. What it entails is the first part of it is a personal history. And if you look at it, it basically, the first 3 questions are, have you had chest pain? Have you had syncope? And have you had palpitations? So chest pain, syncope, palpitations are the most common. But you have to read into it in detail. It's not just any chest pain. but is chest pain related to exertion? Because chest pain is common. It's very common. And if you just start sending every patient for chest pain to a cardiologist, it may be more than half your patient population. Same goes for syncope or near syncope. Vasovagal syncope, so common. Everybody, almost every patient, when you ask them, do you get dizzy when you go from sitting to standing position? The answer is going to be yes. So that's very different from somebody with exercise induced syncope. And then palpitations, same. The next are, have you ever had a heart murmur? Do you have blood pressure? Your history, or have you been restricted from playing in sports by somebody in the past? So sometimes you kind of look at this and you're like, really? I mean, is this really a question? And I'll share an example of a kid who actually had a cardiac arrest and passed away. And he had been restricted. He had been seen by one cardiologist who knew he had a cardiomyopathy, told him you cannot participate in sports. And then he went for a sports screening, didn't divulge that he had a cardiac condition. I don't know if that was asked, but ultimately had a cardiac arrest. And then they look at the sports screening and he had been cleared from the sports screening. So sometimes kids won't tell they have a cardiac condition, but if you ask them, hey, have you ever been restricted? Then they will say yes. And then you can kind of get to why were you restricted and what happened. On the family history, we talked about so many of the cardiac conditions that are autosomal dominant. So I think family history does play a significant role. But again, I think I would be careful. The questions are more to, what they say is, has anybody less than age 50 had a cardiac condition? Now, I think if you just start asking that, there's a good chance you'll find a lot of patients, kids who've had some relative who's less than 50 had a cardiac condition. But I think what you have to rule out is, was that patient who had the cardiac condition, was he obese? Was he a diabetic? Was he a smoker? Was he unhealthy? And if you have an explainable reason, then I don't think they necessarily need a cardiology referral. It's more to do with an unexplained reason, a sudden death from an unexplained cause. Those are the ones that warrant cardiology referrals. And finally, the last part of it is physical exam. Well, you're going to listen. If you hear a heart murmur, especially in an athlete, sure, you say they warrant a cardiology evaluation. Femoral pulses to rule out coarctation, high blood pressure, and if they have the stigmata of Marfan syndrome. So that's the 14-point questionnaire that's out there that's most commonly used in our schools today. The AAP also has a 4-question screening tool that's out there, but I think it's very similar to the American Heart Association. And what I did was I put in bold the questions that are out there. The first one has to do with, have you ever fainted? The second one is exercise-related chest pain. The third one has to do with family history of heart problems. And the fourth one is also with, family history of hypertrophic cardiomyopathy or any family history of somebody less than 50 years of age. So family history and chest pain and fainting, but, don't send every fainter, don't send every chest pain, and don't send everybody with family history. Get a little bit more, and you'll be able to weed out a lot of the patients that don't need, majority of them, and, the few that do, you'll be able to pick those up. So this is a debate that obviously we don't have time for today. And what I've noticed is more and more pediatricians are now doing EKGs in their clinics. So should we be doing EKGs or should we not? Does it help to do EKG as a screening tool? And it's a growing debate, especially if you look at some of the European countries and Japan and other countries that are developed, that are advocating and doing EKGs, and published data in the New England Journal that you can reduce the incidence of sudden cardiac death by using EKG as a screening tool. So the questions have been raised. Why are we not doing that in the US? Why are we not doing EKGs on everybody? And the answer is, first of all, the US is a huge country. Our population is much greater. Our resources are limited. the EKGs do have poor sensitivity. We know they have a high false positive rate. And because of the high false positive and poor sensitivity, we know that there'll be additional testing that will come up, such as an echocardiogram and other things, and restricting them from sports when they may not even have the condition. So it's a debate, but if cost was not a factor, if you take cost out of the equation, then I think you can make a pretty good argument that we should be doing screening EKGs. Now, that's my take on it, but cost is a big factor and we cannot ignore that. So currently, the American Heart Association guidelines have advocated for the American Heart Association 14-point questionnaire and not included EKGs in the non-professional athletes. But if you go to the professional athletes, if you look at the NCAA athletes, or at least the professional athletes, the football players, the basketball players, they all get an EKG, and not just an EKG, but they also get echocardiograms. So they have the resources, they have the finances, and they get the full screen. So let's end with 2 audience response questions, and then I'll open it up for questions, which I hope there will be. Screening for cardiovascular causes with a resting EKG will not help identify which of the following. So EKG will identify all of these except for one: hypertrophic cardiomyopathy, arrhythmogenic cardiomyopathy, which we talked about, long QT syndrome, catecholinergic polymorphic VT, and Wolff-Parkinson-White or WPW, which we really didn't talk about much, but very prevalent and very curable condition. So we'll put the audience up there. Okay, very good. I love it. I love it. The responses are coming through, and overwhelmingly people have picked the correct choice, which is CPVT. We can share the audience response at the poll at this point. And yes, it's a tough one because CPVT can be picked up on an exercise EKG, but not on a resting EKG. And everything else is going to be normal when you do. So this diagnosis can be missed. Please remember, exercise-induced syncope, red flag, send them for referral, and also if there's genetic family history, because it is autosomal dominant. Hypertrophic cardiomyopathy can be picked up on an EKG, arrhythmogenic cardiomyopathy can be picked up, Wolff-Parkinson-White can be picked up, and long QT syndrome can be picked up on EKG. Okay? And I'll do the last question for audience response. And genetic testing can help identify all of the following causes of sudden cardiac death, except. So genetic testing can be helpful. Be doing more and more genetic testing in today's day and age. Prolonged QT, CPVT, Brugada syndrome, anomalous coronary artery, or hypertrophic cardiomyopathy. So it can help with all of them except for one. One of them is not genetic. The rest of them are all autosomal dominant genetic conditions. And genetic testing can help identify them. And excellent, we can share the response at this point. Majority of you picked anomalous coronary artery, which is correct. That is the correct choice. The rest of them can be picked up with genetic testing. So I hope, everybody's getting the picture that where EKGs are, how helpful they are, how the screening tool is, and also with genetic testing now becoming more and more prevalent and available, how genetic testing can help us in our evaluation, in our diagnosis, which are the kids that we worry about, which are the kids where we don't worry as much about. So it's not just about the questionnaire, but, can get into it in more detail as you see these kids. So I'm going to conclude with just my take-home messages, targeting more aggressive screening to higher risk groups, and placing AEDs whereby arrests are more likely to occur. So if you're involved with schools, if you're involved with school nurses, educating them, if you had an AED, where would it be most helpful? Where would you want it to be so it's got the greatest chance of being used? AEDs definitely help. I think I've seen too many cases now where AEDs in schools have helped, have saved lives. So please, advocating for AED is a good thing. It wasn't always the case. When I started, there was a huge pushback from the schools that did not want AEDs, but I think in today's day and age, most schools have it, and those that don't, please advocate for those. And then ongoing studies of incidents should focus on addressing the issues outlined above. So there is data being collected by CDC, and hopefully we will have more data. We'll learn more about it as time goes by. As we've learned more about CPVT in the last decade, there'll be other conditions that we learn about as genetic testing becomes more prevalent and we learn more about it. We'll learn, we'll find newer conditions. But this is preventable, sudden cardiac arrest, sudden cardiac death. And hopefully with everything that we learned today, each of us can save a life and prevent a sudden cardiac arrest or death in the near future. So I think that's my last slide. I have my email on the bottom. If anybody wants to reach me after the talk is done, feel free to do so. It's always a pleasure talking to all of you and having such a great audience. And I'm open to questions. So I don't know if there's a chat box or you can speak up. You can unmute yourself at this time and ask questions. I'm sure, Dr. Agrid, you have some questions since you've been so involved with the AAP, but anybody else, I have about 8 minutes for questions.
Yeah, let me ask, what proportion do you think of sudden cardiac arrest and/or death is missed by pediatric screening? And what proportion of kids do you think we are screening who go into athletics?
So, I mean, it's a tough one, Dr. Agron, because if you look at it, if you're saying what proportion are missed, anybody who's had a sudden cardiac arrest somehow got missed, right? Because they were at risk for it. Especially for conditions such as long QT syndrome, WPW, hypertrophic cardiomyopathy. And I can tell you that that incidence has gone down. At least in the first couple of years when I was at CHOC, we had about 5 sudden cardiac deaths a year. I think that incidence is now maybe 2 to 3, so at least half of it. And if you look at it, nationwide and you include all the hospitals, that's what you're going to probably find. How many get picked up with screening EKGs? I think a fair number. I have seen a fair with the screening EKGs that are done. I've had referrals for Wolff-Parkinson-White syndrome. I've had some referrals for hypertrophic cardiomyopathy. So yes, these patients are getting picked up. I don't have an exact number, but I think clearly it's helping. Now, the flip side of it, I do want to add that there are false positives. So you're picking up patients, but you're also, it comes with its side effects, which is the false positive that gets sent for unnecessary testing or get restricted when they really don't have to for at least a little bit till they are completely evaluated and released. So that's what the debate is. Other questions? Tomas, I wasn't seeing the chat box. Is there anything in the chat box? I can't see it, so.
No, there are no questions in the chat box at the moment. So we do have 6 minutes left.
Anybody want to share stories?
Actually,
cases
we have
they've
one.
had?
We
Okay.
have one from Dr. Patricia Nishikawa. It says, should pediatric athletes who survive commotion cordis be allowed to continue to participate in collision and contact sports?
At least in my world, I would say the answer is yes. Once they have completely recovered, it's like getting hit by lightning, right? What are the chances that's going to happen twice? And it can happen to anybody. So I don't think just because you had it once increases your chance that it's going to happen a second time. And Damar Hamlin's a great example. He's back to playing football now. So, and I'm sure he was evaluated by some other experts all over the country before returning to sports.
And you can go ahead and put your questions in the chat or unmute your microphone and ask any question you would like.
Yeah, if somebody has, I was going to say personal stories of patients or things they've experienced that they want to share with the rest of the audience. This is a great forum for that too, because I think we all learn from everybody's experiences. Dr. Malkin is here too. Hi, Fred. Well, if you don't have questions, we give 5 minutes back to everybody, and you guys can go with your families and have dinner. And like I said, my email's on the bottom of my of the last slide, so please feel free to reach out, and it was a pleasure.
Okay, and before you go, we have one more from
Okay, please.
Samuel Kim. Would you recommend that pediatric athletes who play the higher risk sports such as basketball, football, and soccer be screened even though there aren't any guidelines for that?
So screen with what is the question, right? So the American Heart Association, the 14-point questionnaire, the answer is yes, everybody gets screened. So the question really is, what do you want? What do we do beyond the 14-point questionnaire? And I have to say, at this point, you have to go with the guidelines, and there's a reason the guidelines are out there, because they look at everything. And the current recommendation is not to do an EKG or an echocardiogram. Now, in individual cases, if you feel that that can be done, are there individual pediatricians who are doing it? Are there individual family members who feel like, hey, I want my kid screened? Yes, it's happening. And you know, we see it all around us, but as a guideline, as a bucket statement, I think we have to go with what the societies recommend.
Thank you. So from Dr. Don Pedro, for patients who are treated with stimulants, what heart rate range is too high to start thinking of stopping that stimulant or to changing to a non-stimulant?
Yeah, I don't particularly look at the heart rate. I think, you know, a heart rate is just a number because we don't know what their baselines are. There's a lot of patients that have baseline faster heart rates, depends on their conditioning level, et cetera, et cetera. So what I would say is if you're worried and everything else in their cardiac, their cardiac exam, everything else is normal, and it's just a heart rate. And the stimulant medications are helping them. That's the other thing to keep in mind. Don't just go up on the stimulant medication just because, you know, it's okay to go from a cardiac standpoint. You have to kind of weigh the risk and the benefit. And I tell every family when they come to me for evaluation, I said, you know, there's no free ride. At some point,